Good afternoon, everybody, and welcome to the first of our 2026 bi-monthly Rural Health Clinic engagement meetings hosted by the Colorado Department of Healthcare Policy and Financing. And Happy New Year. Since we are now 5 minutes after the hour, I'll go ahead and get things started. Let's go ahead and go to the next slide, please. All right. So before getting into today's meeting, I wanted to reiterate our mission here at HICPUF, which is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Next slide. All right. So just to introduce myself, my name is Andrew Abalos. I am the Facility Rate Section Manager here at the Department of Healthcare Policy and Financing. I'll be presenting the material during today's meeting. So this meeting will be recorded. So if you have any questions for me, please make sure that you're speaking clearly and mention the hospital, clinic, or other entity that you represent. This will help us in the event we need to follow up after the meeting to address any concerns you may bring up. And additionally, since this is recorded, we will post the recording to our website, which will allow you to forward this information to others that may have missed this meeting. And just being in a quiet area and speaking clearly can help us preserve the integrity of that recording. So this slide just shows some information on the timing of these meetings, both reiterating the webinar link and the conference line information. Our next meeting is currently scheduled for March 5th, 2026 at the same time. And to express a little more about the intent of these meetings, I would like to think of these meetings as trying to establish an active forum by which we at the department can hear directly from rural health clinics regarding the issues that they face, particularly around rates. And while we at the department have prepared material for today's meetings, we also want to think of this as an opportunity to collaborate with the RHC provider community and develop our agendas in alignment with that. So we'll have a little bit more on that during this presentation. But let's go ahead and go to our next slide. Okay, and this is our agenda for today. We have a few educational topics planned for today's discussion, just as we've had in the past, as well as some reminders on processes relating to rural health clinics, and just some updates on the 2025-2026 rates. I'm gonna stay on here for just a moment. And yes, let's go ahead and move forward to our next slide. All right, so just wanted to provide a brief update on staffing for those that this may be their first meeting. We used to have an FQHC RHC rates analyst who is no longer with the department, which means that I, the facility rates section manager, am serving as the point of contact for all matters relating to RHC rates. We're actually in the process of hiring this position and are hoping to have somebody here shortly, but unfortunately they have not started yet. So we will let the provider community know once this position has been filled. So that way they can also serve as another point of contact for RHC rate related matters and could get a little bit of help just in responding to some of the inquiries that come our way. So we will have more information on who that point of contact will be in our next meeting, but as mentioned, we just do not have that position filled quite yet. Let's go ahead and move to our next slide. Okay, and then similar to the previous meetings, just want to go over the rate methodology overview, just to add some clarity into the way in which Colorado Medicaid sets its rates for both the freestanding and the hospital-based RHCs. So this slide right here is going over the rate setting for freestanding RHCs or independent RHCs. So we set rates that are the higher of the prospective payment system or PPS rates that are established by BIPA in 2000, or the alternative payment methodology rate, which is the Medicare upper payment limit for rural health clinics. Let's go ahead and move to the next slide. Okay. For the new freestanding RHCs, interim rates are set as the average of other freestanding RHC rates in that RHC's raise. We follow a similar process for establishing the PPS rate for new RHCs, which relies on the average of other RHC PPS rates within that same ray. Okay, so next slide. So in general, what this means for most freestanding RHCs is that these RHCs are being assigned the Medicare UPL rate, which are listed here by calendar year. This table shows the current trajectory of freestanding RHC rates through 2028. And since we are now in 2026, this rate should soon be active for those freestanding RHCs within our claims processing system. More on that later. But please move forward to the next slide. Okay, this slide shows the methodology for our hospital-based RHCs. Similar to the freestanding RHCs, encounter rates are the higher of the PPS rate and the APM rate. PPS rates are calculated the same, but here APM rates are based on actual costs. So for the APM rates, each year, PPS rates are calculated and compared to the most recent audited and finalized cost per visit from the Medicare cost reports from the corresponding hospital cost report. Those rates are used to set the current year interim rate. After an RHC's Medicare cost report has been audited and finalized, the department performs a reconciliation for the services provided. Reconciliations are calculated based on a comparison of the number of visits that are reported and the difference in interim and finalized rates for the year the cost report covers. So this can result in payments to hospital-based RHCs or recoupments if necessary. So to provide a little bit more of an example around those timelines, actually, let's go ahead and move on to the next slide. That'll help out to provide insight there. Okay. And actually, yeah, let's go over this one first. Okay, so for the new hospital-based RHCs, they have interim rates that are calculated as the per visit encounter rate established on the Medicare rate letter. So when you're enrolling as a provider, I believe that that's information that will be requested, or a sister clinic's per visit encounter rate in that order. And then the new hospital-based RHCs will have their PPS rate calculated based on average of 2 years audited cost and visit data from that cost report. So to provide a little more insight into how the scheduling of how the finalization and auditing of those work, the cost reports, the department works with its auditor, currently Myers and Stauffer, to obtain the finalized rates towards the beginning of each calendar year. So that looks like we are looking at the HICRIS data and reviewing some of the previous years and seeing which hospitals have RHCs that have finalized cost reports. Because it takes a while for CMS to audit and finalize those cost reports, sometimes that means we have to make reconciliations well into the past. So for example, it might be the case that during the prior calendar year, say in this instance like 2025, an RHC may have had their hospital's cost report audited and finalized for a previous year, say, for example, one in 2022. When we do these reconciliations, we are now looking at those audited and finalized cost reports, and then we will use that rate, if that is the most recent cost per visit rate as found in a cost report, for the 2026 time period. We will also retrospectively go back and evaluate the 2022 utilization data to determine how did our payments compare to that audited and finalized rate for 2022. That is when the reconciliation will be performed, and that's why it's cost-based, is that way we can help sort of create those payments to help make it 100% of the cost per visit rate. So let's see, let's go ahead and move to the next slide, please. All right. So as mentioned in this top bullet here, we're looking at historic claims data, and whenever we complete those calculations and have them move through our internal processes, which includes clearing that up through our leadership and making sure our budget has an opportunity to review, we send out and distribute letters that describe those one-time lump sum payments or recoupments. So we have been a little bit behind on this, but we were working on the 2025 reconciliations, but with, again, the departure of the FQHC RHC analyst, as mentioned earlier, this work has fallen a little bit behind. However, we do plan to aggregate the information that we're getting in this current time period for 2026, along with the 2025. So we're going to wrap all of that work into one reconciliation period, and all the cost report and cost per visit data that we've received for 2025 and 2026 will be put together into one single reconciliation. So what that means for the hospital-based RHCs is that We are going to combine those efforts and distribute, hopefully, letters when we have them completed and cleared, so that way we can perform those payments and recoupments for any of the cost reports that have been finalized as of the data collection that we've done earlier this year. Okay, and next slide, please. All right, so we're moving on to a slightly different topic here, but this is something that came up during our September 2025 meeting. We discussed the idea of posting the rates for all RHCs, so that includes the freestanding and the hospital-based RHCs enrolled with Colorado Medicaid. We would like to post those rates to our public-facing website with the intent of adding some transparency to our existing payment rates. We also had a call to action that we followed up on in November to let at the very least, collect feedback for any concerned parties, letting us know if there would be any problems with that. We didn't receive any feedback from that, so we're going to still move forward with creating that rates posting. From the department's perspective, we don't see this as necessarily an issue because these rates are publicly available via the hospital cost report database that CMS hosts. So realistically, this serves as a method of collating that data and providing some official insight as to what the RHC rates that we're currently paying at for various RHCs. Okay, and next slide, please. Okay, so just more following up on those 2026 rates. So we are currently in the process of sharing data with our auditor for those rates that are to be effective January 1, 2026. In particular, this is just validating that the PPS rates haven't exceeded the Medicare UPL rates for those freestanding RHCs, as well as looking at the hospital-based RHCs and the cost per visits there. Part of the data sharing is that we do have several RHCs that are enrolled in our system, and we want to make sure that our auditor is collecting a holistic set of RHC cost reports or hospital-based cost reports. So that way the respective RHCs can ensure that their utilization is being captured for when we actually perform those reconciliations. So we're still working out some of those finer details on completing that comparison of data. And then shortly after that, we do anticipate that we'll be able to work with our contractor, have them develop those or send out those rate letters, and at which point we'll begin working on the reconciliations. We'll also, shortly after those rate letters are distributed and everything is finalized, we'll be implementing those rates into our MMIS, and hopefully that is coming within the next month or so. And so that way, once those are corrected or once those rates are implemented, we can perform a mass adjustment to any of those claims that have already been submitted. So that way they are paying at the correct rate. And again, just our typical timeline of this annual process is our contractor is performing a data collection generally during the final calendar year or final quarter of each calendar year from whatever's loaded in that CMS database. So that way, at the beginning of the year, they are creating a listing of rates for us that they have collected for us to implement into our system after we have done our review and those rate letters have been distributed. Okay, and next slide, please. All right, so we want to just keep this in mind, so I'm regularly presenting on this one as well, but we want to remind our RHCs that we do have a scope of service rate adjustment process in place. And this is us being compliant with BIPA, as mentioned earlier. This process is to allow adjustments to an RHC's PPS rate whenever a valid change in scope of service takes place. So there is a URL at the bottom of this slide, and if you are interested in participating in this process, that URL will contain instructions and an application for requesting a change in the scope of service. Those instructions contain guidelines for what is and is not considered a valid change in the scope of service. So if this is something that you're interested in, I highly recommend you review the guidelines on the site. And if you do have any follow-up questions on any of that, feel free to reach out to us. I may not be able to immediately know the answers to those questions, but we can always follow up internally after some research and maybe do some work with our auditor to make sure that those questions are answered. Okay, and next slide. All right, so this is also a reminder on a potentially missing revenue stream that we just want to make sure that our RHCs are aware of. But this is what we refer to internally as our managed care accuracy audits. Managed care entities are required to reimburse RHCs an amount no less than the encounter rate set by HCPUF. So RHCs are invited to participate in this process in a few different ways. First, if an RHC does not submit quarterly data, then HCPUF will determine that the facility has been paid in full. Second, the facility can also notify HCPUF that they have been paid in full. And then last, facilities can submit data indicating that payment is still due. So we'd like to emphasize that it may be optimal to try and reconcile this with the relevant MCEs prior to the submission of such data. But this purpose exists so that way, if there's any challenges with that, then the department can collect the data and make that determination of how much funding is necessary to make sure that the payments are still no less than the encounter rate set by HCPUF. So like I said earlier, this is a call to attention on a potentially missing revenue stream to RHCs from those managed care entities, which is why this is listed here. We do have a point of contact, Kennedy Vance, for these meetings. And while Kennedy is not present during today's meetings, Kennedy agreed to have her information on the slide and serve as a point of contact for this process. So again, if you are interested in participating in this process, there's more information at this URL here. If you've already reviewed it and still have questions, then Kennedy Vance can serve as the point of contact. Okay, and next slide, please. All right, so this is the fourth iteration of this particular bi-monthly meeting. Some of the topics do seem a little bit redundant, but we want to make sure that we still have an opportunity to engage with the RHCs that are of topics of interest. And while we want to continue having these meetings, we're going to emphasize some of those operational updates. For example, when rates are loaded into the system, when mass adjustments are taking place for those claims, as well as any updates regarding the reconciliation process, or if there have been any changes in the scope of service request changes or the managed care accuracy audits. So those are going to be what I consider mainstays of these meetings, and I'll continue to go over them. However, we do understand that there might be other topics that rural health community or rural health clinics and maybe some of the stakeholders that surround them might be interested in. So again, in the interest of making our agendas collaboratively, we do want to hear from you. So I have my email address listed here. However, I do want to open up the conversation to see if there's any interest in discussing things that are currently of interest right now, or maybe considerations for how we can modify the agendas of these meetings to make sure that they are still of interest and we still have attendance for these meetings. So like I said, just want to open it up. I'm going to go ahead and stay silent for just a moment here, see if there's any feedback. All right, I'm not seeing anything immediately, but can you go to the next slide, please? Awesome. Well, now we are officially at our questions, comments, etc., as we've reached the end of our prepared material. So just one more opportunity if you have any questions or comments for us. Okay, and I do see a message in the chat. Looks like Rick says, thank you. This has been very helpful. One implementation question we're hearing from rural providers is how to operationalize existing reimbursement pathways, particularly MIH/CP, treat in place and telehealth enabled follow-ups while meeting our HTP reporting and sustainability expectations. It would be helpful in future sessions to discuss practical implementation approaches that support documentation, audit readiness, and provider-led collaboration without changing rates or billing rules. Well, number one, thank you for the comment. I do think that the topics that you're bringing up is something that I would like to discuss a little bit more with our policy folks. In general, whenever we do any sort of effort across the department, we tend to examine, what sort of payment policies do we have in place around this? How might it impact existing rates? However, the group that is here right now is maybe a little less knowledgeable about EHRs and sort of the operational side of a lot of what's being discussed here from the rural health clinic side. So I do think that that's an interesting topic, and I would like to maybe take that internally, see who might be able to better speak to that. And Rick, I believe actually I received an email from you earlier this morning. May follow up with more questions about the specific um, question that you're hearing. So we can commit to doing a little bit more follow-up, and then this can be perhaps a topic of conversation during our March meeting. And thank you, Rick. And anything else that anybody wanted to bring up? Not really seeing anything or hearing anything. Go ahead and move on to the next slide. Right. So here's some contact information for us over at HickPuff. Again, I handle the finance side things. I'm the facility rate section manager. Once we do get that rate analyst hired, their information will be here as well. On the right side, you'll see contact information for Morgan Anderson and Janelle Gonzalez, who work more on our policy side. So it's very likely that the question or the topic that was brought up in the comments will be addressed with that group. So overall, if you do have any questions, any of us, just please send us a message. If we're not the appropriate people to respond to it, we'll work internally to see how to get you connected to the right person. But otherwise, I believe that is the end of our prepared material. So with that, please get in touch if you do have any follow-up questions or comments, and we'll plan to chat again in March. Thank you so much for your time.